So I will focus my my talk on the effect or the impact of nutrition or malnutrition or undernutrition to the digestive cancer patient journey, to the prognosis, to the overall survival, and to the response to treatments, which is probably the most impactful role of nutrition in these patients. So to contextualize the main issue, cancer wasting in cancer patients is indeed a very big problem still, and we do know this from the first papers published in 1982 from the group of DiCE, that 8 to 87% of cancer patients may develop undernutrition, and weight loss may be very severe, specifically in high-risk cancer patients, the diagnoses that have high nutritional risk, like head and neck cancer, esophageal cancer, stomach, pancreatic, lung, and also colon rectum, specifically in advanced stages. These are some data from Portugal, from one of my students. She's a dietitian, and she recorded, she evaluated the percentage of weight loss of her patients that were admitted to treatment with chemotherapy. And they were 465 patients, and she simply evaluated the weight loss of these patients consecutively. And as you can see here, weight loss is still in 2019 the date that these data were presented in the CACAXI conference. The percentage of weight loss is expressive, specifically in upper GI cancer patients, in colorectal as well, and also in lung. Besides the location of cancer, percentage of weight loss was also very impactful, considering the advanced stage of the disease, as you can see here in stage 4. These are posterior data from an MD. She's an oncologist, and she evaluated consecutively the patients that were referred for curative and palliative chemotherapy, 561 patients. As you can see here, 34% of these patients had lost weight in the previous months, and more than half of these patients had lost a significant amount of weight in the previous 6 months. And as for the overall nutritional status of these patients, 76% of these patients were moderately malnourished, and 13% were severely malnourished. And 84% of these patients were evaluated as in need of an urgent nutrition intervention. The impact of the overall parameters of nutrition in survival opened a very wide landscape of research opportunities, where we started focusing on outcomes, on metabolism in the area of cancer and oncology, with the main goal of studying the impact of nutrition. And we started realizing that more than the overall quality of life of the patients, of the physical compliance, of the functional capacity of these patients, nutrition and critical weight loss impacted the treatment response, the response of the patients and the tolerance of the patients to their own treatments. This is a different study from another dietitian, Carolina. She evaluated head and neck cancer patients, and she tried to understand if patients with a more severe weight loss had a different behavior in terms of the disease progression and of the disease aggressiveness. And what she found out was that patients that, from a CT point of view, from the image of the evaluation of the cancer progression, patients were more likely to present a complete response after chemo and radiotherapy if they did not present severe weight loss. Those patients that had presented severe weight loss were indeed more unfavorable in terms of the complete response to the chemo and radiotherapy cycles.
More favorable?
No, more unfavorable.
Oh, okay. Sorry, I'm not aware.
Without weight loss, patients that did not suffer weight loss had a most likely chance of having a complete response in comparison with the patients that had severe weight loss. This is another study. This was a randomized controlled trial, a multicentral study that we did in collaboration with Helsinki University. And this is just a Kaplan-Meier curves. And we stratified patients with cachexia and patients that did not have cachexia, and the impact of this cachexia status on the overall survival. And you can see here that 1/3 of the patients had cachexia, and this was significantly associated with a shorter long-term survival after treatments. In a different kind of cancer patients, this is another study, a PhD project from another MD, David. He's studying a metastatic colorectal cancer, and this data was just the preliminary data from his project. And he included these patients and studied the body composition and the muscle mass, the adipose tissue, and if this in a more detailed fashion, more than percentage of weight loss and more than simply undernutrition, if muscle loss and body composition were and in what amount did impact the overall survival. And as you can see here very elegantly, these Kaplan-Meier curves, patients that had lost muscle and had a significantly amount of sarcopenia, they did have much more unfavorable outcomes and survival curves as comparison with the patients that did not have sarcopenia, here in green, patients that did not have muscle loss. In detail here, I just added this slide just for you to see the numbers. In terms of survival, if we have patients with normal muscle, we had a 37 months overall survival free from disease, in comparison with patients that had muscle loss and excess body weight with 13 months, in comparison with 5 months patients that were obese and had a severe amount of muscle loss. And in clinical practice, you can find patients that are overall undernourished, patients that are typically cachectic. You do have patients that probably from an objective, from a global evaluation, you do see patients that look like they have a regular nutritional status, that they are fairly well nourished, but they probably present reduction in muscle mass, or you can have obviously patients that are obese and they have an excess adiposity. And what is cross-sectional to these three phenotypical cancer patients that we see in clinical practice is the loss of muscle in all of them. And this loss of muscle may come also not only from an impact of the disease itself, but also from the toxicity of treatments and because of metabolic alterations that these patients present because of treatments and because of the presence of disease. This is an ongoing project that we have in our hospital in patients under radio and chemotherapy. And we started focusing on the nutritional intake of these patients, focusing on protein intake. And what we have found out until now, patients with digestive cancers, they do have a very deficient intake of protein, shown here from 0.4 to 1.2 grams per kilogram per day, which is very low in comparison with what cancer patients need. And cumulatively, these patients with a more reduced protein intake, they also have a high inflammatory status in comparison with patients that ate better and that had a higher protein intake in comparison to the requirements, the daily requirements. And these patients with a higher intake also presented a lower inflammatory status. And indeed, protein intake is a big concern in the priorities for cancer care and for nutritional intake in cancer care. And indeed, the ESPEN guidelines that we were able to update on 2017, we did focus on the importance of ensuring an adequate nutritional intake during cancer treatments, and the priority would be and is also to implement the nutritional intervention as early as possible and in accordance with what we call daily on evidence-based nutritional counseling, which what is required is that we have to assess patients' nutritional status and perform an overall nutritional intake in these patients, the assessment of what the patients eat, what are the dietary preferences of the patients, the habits and intolerances, the diary meal distribution, psychological status, and an overall symptom assessment. And only with all of these evaluations, we are able to prescribe an individualized diet. And after this, we should and have to inform the patient and the family and the caregivers on the importance of the diet and exactly what we intend to aim with this individualized diet, and explain the intake that we are prescribing in accordance with the patient's requirements. And this individualized counseling consists from a very pragmatic point of view in prescribing therapeutic diets that are modified to fulfill specific requirements of the patients in terms of digestion, absorption, disease stage and progression, and the impact that the disease has on the patient's overall status, psychological factors, symptom modulation. We should, from a clinical point of view, maintain as possible the usual dietary pattern of the patients so that we have the highest compliance possible, and the prescription of the diet in type, amounts, and frequency of eating throughout the day is very intimate to patients, to dimensions of the patients, to the disease, and to the overall therapeutic goals. And in this sense, we were probably one of the first groups that started to investigating the impact of the individualized diet on patients' outcomes and prognosis. And this was another randomized trial that we have performed in head and neck cancer patients. And with an individualized intervention, timely individualized intervention, we were able to prevent deterioration of nutritional status and incidence of malnutrition during chemo and radiotherapy in very high-risk cancer patients. This is a very recent systematic review that we have underway for publication in the journal Nutrients. This was a review of studies since 2012, where we focused on what we are starting to call nowadays as the multimodal intervention for to improve outcomes in cancer patients, which comprises nutritional intervention with nutritional counseling, individualized diet, eventually with supplements, but also on the impact of exercise intervention cumulatively with a nutritional intervention. And indeed, in gastrointestinal cancer patients and also in lung cancer patients, results of this systematic review do show that it has a very important impact on reduction of muscle mass, increase in muscle mass as well, and increase in muscle strength of these patients. And what we want to witness from a routine point of view is this transition. This is a slice of a muscle on your left, normal or at rest. And what we do see and what we want to stimulate is this type of hypertrophy of the muscle cells, where you see a larger or enlarged volume of muscle cells post-intake and post-exercise and physical training. When we talk about nutrition intervention and more than proteins and more than the overall energy intake, we also started to assess around 30 years ago, 20 years ago, the impact of specific nutrients in the overall nutritional intervention for cancer in terms of probably a therapeutic effect of high doses of some specific nutrients. And one of those nutrients and one of the most studied ones is EPA and 3 fatty acids, polyunsaturated fatty acids, and the impact on weight loss. And this was probably one of the first papers. And I always like to show this figure because it's very illustrative of what happened to these patients. These were weight-losing pancreatic cancer patients. And you can see here, before the EPA started, the supplements with omega-3 fatty acids, the weight loss was very significant, and all patients were losing weight. And when they started the supplementation with the N3 fatty acids, you see simply that only by looking at the trajectory of weight loss, you see a major difference in terms of the angle and the amount of kilos that the patients were losing in the previous months before the start of this supplementation. And indeed, we are starting to understand that probably some nutrients, specifically N3 fatty acids, may have more than a nutritional outcome impact in terms of the overall survival of the patients, but eventually as an adjuvant to the chemotherapy cycles, to the drugs that we use to control the disease, and eventually to some cycles of radiotherapy in some patients. And indeed, N3 fatty acids specifically have been shown in some types of cancers that it probably will have an effect in terms of preventing recurrence from the cancer in the long term, reducing treatment toxicity, long-term toxicity as well, and eventually, as an adjuvant, it may have the potential to increase chemotherapy, the chemotherapy tolerance, and the chemotherapy efficacy of the drugs. So in conclusion, and taking into consideration all the published data so far, undernutrition and poor nutritional intake in cancer do influence in a very significant manner morbidity and mortality of these patients. Muscle loss is indeed a predictor of worse survival and dose-limiting toxicity in cancer patients. And what we need to prioritize is a timely and adequate nutritional intervention to improve functional capacity, physical activity, and overall quality of life, but also to maintain the immune function as optimal as we can, to reduce treatment morbidity and improve treatment tolerance, and eventually improve treatment response and efficacy and the overall survival and prognosis. Thank you. And this is what I wanted to share with you today. Thank you.